And what I want to do is to take advantage of information that I've received over the last couple of days to offer you updates on the distribution of the pandemic, also offer you updates on some of the response issues, and then dig a bit into the way in which public health responses are changing and are becoming more localized. And I also want to try to go through some of the challenges on vaccine distribution. I will aim to complete these summary points by 1:30, and then we will have the quiz, and I would like to open up for discussion. And straight away, as we go in, I'd just like to welcome everybody into the briefing. Those who've been before, thanks for coming back. Those who have stumbled on us, welcome. It's half an hour of review and then half an hour of discussion is our usual style. I'm really keen today that if you would like to make a comment, you will let us know by putting a remark into the chat, because the way in which we're working at the moment is that my colleagues are looking at the chat and then are helping me to know who would like to speak. As I was reviewing the epidemiological information about this pandemic and trying to get a sort of point of view that I thought would be useful to share with you, I was thinking once again about how this, because of the way in which it's transmitted, is really not sweeping across countries in waves, but instead is appearing in these spikes of disease that then surge up and cause outbreaks. And I thought I would just give you a little bit of a view of the epidemic curves, knowing, of course, that these epidemic curves are incomplete, given that we don't have information from everywhere. There are always problems with the data. But just if you have got a screen that shows you what's going on, if you look at the bottom left-hand corner of your screen, the colored curves that you see are actually the information WHO has about the numbers of cases reported from different parts of the world. I mean, it's an enormous reporting, this 461,000 new confirmed cases of COVID-19 reported in the 24 hours before 10 a.m. on the 24th of March. So it's a couple of days old, but really this figure is just reminding us all the time that we are running with a huge number of people with this disease, nearly 500,000. The number had dropped quite markedly in the end of February. And I kind of, like many other people, was thinking, well, perhaps the overall scale of this thing is going to go down. But it's coming up again, as you can see. So I'm going to just move my cursor around and just to point to a few little features of this composite graph. Well, we go back to last year and the thing began. There's Wuhan just under my arrow, right? Just a little tiny pimple really on the graph. And then the virus comes into Europe and the US in April last year, and the overall figure starts to climb. On this, the yellow part of the area is US and Latin America, it's the Americas, and then the green part, where I'm moving my cursor at the moment, is Europe. The purple part is South Asia, that's mostly India, and then we've got also Middle East, which is a light blue color, and then dark blue is Africa. Just the reason why I wanted to show this is just to help you get the quick understanding of, firstly, how this is still really huge in terms of volume, with daily cases up to pretty much where they were at the end of last year. And just inside this, please note that the purple part of the histogram is widening again, meaning that we are getting more cases coming in the Indian subcontinent. I'll just give you a little more detail on that in a minute. And we're also getting more cases coming in the WHO Middle Eastern region as well. So altogether, the quick story, as I said last week, it's not a big shift, is that numbers of cases are rising again. And having got down to under 400,000 a day some weeks ago, we're back up to nearly 500,000 cases. But the death numbers have not come up, and that's good news. But you have to remember that the death numbers tend to come about 4 weeks after the case numbers around the world. And so I thought I'd just tell you a little bit about what this is leading to. Here's a report I got from colleagues in the Philippines. It says that healthcare capacity is overwhelmed in Manila. Numbers of cases reported in the Philippines has been increasing exponentially. And last week, 7,000 cases were reported daily for 3 days. That's the highest since the start of pandemic. And so the story is one of very high bed occupancy rates in hospitals. And therefore, the policy response by the government is to invite people not to move around, to try to restrict contact, and exactly what we're seeing in other parts of the world. This is the reaction that happens as health services fill up, is that obviously the authorities reduce the number of contacts that people can have in order to try to bring the case numbers down again. So then switching over to a completely different part of the world, Venezuela, there they've got a big increase in cases. They seem to have variant problems, and that in turn is leading in Venezuela, which has a fairly limited health service at the moment, also to have to be doing a seesaw between having restrictions and having movement. And then we come to Europe, where Belgium has got an increasing number of people with COVID, a bit like what's happening in Netherlands, what's happening in France, and what's happening in Germany. And so Belgium is also trying to restrict contact. In all cases, governments are looking for ways of doing what I sometimes call lockdown light, L-I-T-E, trying to restrict contacts between people in order to get case numbers down, but trying to do it with minimal disturbance to the overall economy. And so the general view in France is that the current movement restrictions are pretty light. They're being varied between departments, but that's because, as with every other country, this country, France, is not in a position to tolerate a strict lockdown. Public would find it very difficult, and also the impact on people's overall economic status and well-being would be devastating. So that's where just about every government is right now. Case numbers coming up again, and the policy choice being made is, do we just try to rough it out and cope with these increasing numbers and cope with our health services being busy and continue to ask our population to restrict on physical contact, or do we actually try to stop movements again? And in most countries in the world, in the moment, again, we're in a phase of movement restrictions because of this upturn that I've just demonstrated on this figure here. I don't want to make any sort of comment about this situation, except to point out that there is no way one can even think internally about this pandemic being nearly over. It's basically spiking and surging in different places as the virus moves around, and the distress caused by the pandemic and by the control measures is absolutely terrible. Still, we have the increasing numbers of reports of poverty and malnutrition all over the world. And I suppose that for me, my main messaging is to remind that it's still here and remind that it really is affecting poor people the worst. Okay, so what's happening in India? I thought it would be a good idea to see if I can flip through and find the India statistics, because it's in this little graph here. There is something happening in India as a whole. If you can just look at the shape of the graph, last year we had very large numbers in India, and then they dropped down, down throughout the year. And there's now this uptick again with new cases, particularly reported from Maharashtra. The deaths not shifting so much. Concerns that there may have been a new variant appearing in India, and a real challenge for the government, which is trying to ensure that the health system can gear itself up to react to a new upsurge in cases, and trying to work out what's happening. Most of my colleagues are telling me that the upsurge is happening in cities that were not hit so badly by COVID last year. So that's why in Maharashtra, it's not Mumbai that's the most affected city, it's more Pune. And so I think that that's important. There's a key question about the India situation. Were there many more asymptomatic cases last year than symptomatic? And was there actually a much wider spread of the virus in society than we realized? Well, a number of serological studies were done, particularly in New Delhi, and they did suggest that there was a lot of asymptomatic spread. And I think that a number of epidemiologists are asking the question about whether there has been rather a lot more asymptomatic spread in developing countries. But it's very varied. And even the serological studies that have been done don't present a consistent picture. So I'm anticipating that there will be a continued upsurge in India. And also there is an upsurge right now in Bangladesh, and also in some of the smaller countries in that, South Asia and East Asia, particularly Timor-Leste. And I was in contact with some colleagues in the city of Dili recently, and to have a serious outbreak of a disease like this in a city that has very, very limited facilities, limited health services, limited oxygen and so on, it is particularly challenging. And so my image right now is that this virus is going into places that thought that they'd been able to avoid it, and it's causing quite serious problems, especially when they have low levels of resources for their healthcare. So I'm talking about the pandemic so far entirely without touching much on the question of vaccines, and that's deliberate, because the point that I wish to continue to make to everybody is that dealing with this pandemic right now is still very much about avoiding getting infected with the virus through personal actions and through actions that can be done by authorities. Now, the personal actions, there's no shift at all. They are maintaining physical distance, especially when indoors, of about 2 meters. Secondly, well-fitting face protection with a good quality cloth or surgical mask. And thirdly, trying to make sure that if you have any surfaces, or also your hands and so on, are kept clean, and that you cough into the crook of your elbow, and that you practice very good personal hygiene. Fourthly, doing everything you can to isolate yourself when you're ill, regardless of your test result, and maintaining that isolation for the appropriate time. In some parts of the world, it's 10 days. In some parts of the world, it's 2 weeks. It varies, but the key point is be isolated. And then fifthly, shield those who are most at risk. Do what you can to make certain that they're not exposed, especially if they're older people or people with other conditions. And then to back all that up, we need well-functioning community-based public health services, locally integrated, trying to make certain at all times that the people who are providing public health services are properly plugged into local authorities. My colleague John Atkinson has been talking extensively with colleagues in public health in the UK. And one of the things he's been questioning is have the way in which public health services work evolved as the test and trace and isolate scheme has become more localized and more plugged into local communities. John, could you possibly summarize in a few words what you have found through your inquiries among the public health community in the UK? Are the capacities to detect and then to isolate people with disease and to trace contacts being better plugged into local administrations so that communities are able to be worked with on a partnership basis?
Thanks, David. Yeah, so give a few words on that. And it's worth remembering the English context. I'm not so up to speed on the Scottish and Welsh contexts, but the English context is one where case numbers are coming down. So it looks different in England to the graphs David has been showing about the global situation. But what are we seeing? First, the directors of public health who look after specific local geographies are seeing this as something that's going to be around for a long time yet. They are planning and hiring staff for 6 months to 18 months forward. They're not taking people on temporarily. So they are not seeing this as by any stretch over, despite the thing that I've seen. They're also saying that the system has shifted. Whatever the national conversations, whatever the headlines about vaccines or whatever else, what's practically happening on the ground is the capacity to identify people locally and quickly has gone up quite markedly. And people are using quite sophisticated systems, GIS systems, where they can plot data on screens and know who's got the virus, where, how old they are, whether it's linked to a school, a business, whatever, is becoming increasingly prevalent. It means, as far as they're concerned, at the current levels of infection, all of them are saying, if we carry on at this level of cases, we can pretty much cope with this. We can find the spikes very quickly and we can suppress wider spread. And that's at about 50 cases per 100,000 in the population. They say if it goes above that, we are going to be overwhelmed again, and we have to go back to broader ways of dealing with things. When we lose that specific wraparound, David, that's so important. But what they're also saying is perhaps two other things. One, the ability to get to people locally with local knowledge means that whole raft of responses that can help people who need support to isolate can be accessed very, very quickly. And they're particularly using some of their discretionary funding very loosely in order to make sure that people who need money to isolate are able to isolate. But the other thing that's coming through quite a lot for me now is business, David. It's that first, the social contract, as we've spoken about, matters. People who don't get sick pay, people who don't get called back in for work if they are ill and don't show because they're on a 0 hours contract, a contract where you're only called when needed. These things are really getting in the way of breaking spikes of infection as they happen. But the other thing that's happening, because we're now in movement restrictions for really some time in England, The social space now is the workplace. Those who have to go to work, they do factory work rather than office work, and therefore have to be physically present with each other. This is where we're seeing a lot of spikes of infection taking place. And so a lot of focus on businesses and their responsibilities, and to not just conform, but to think proactively as to what it is we might be doing going forward. So hopefully that gives a bit of background. Happy to unpack any of that if you'd like to, or others might like to later.
Thank you, John. There are some quite important observations for me in this work that John did last week. The first is the fact that in the UK, the directors of public health are taking on staff to be able to deal with the pandemic for a time horizon of 6 to 18 months. I think that the more people in positions of authority who understand that this is going to go on for a significant number of months, the better. Secondly, the system is shifting in the UK to being locally grounded, which means that the identification of cases and the management of the response is much more tuned in to local community organizations. And as John said, working locally with local knowledge means that you are more effective, which brings to the third point that I really, really want to tune into, which is the judgment that they can handle spikes and stop them from turning into surging outbreaks when the incidence level is running at about 50 per 100,000. But if the case numbers are much higher than that, then the capacity to stop the spikes begins to be overwhelmed. And that's when restrictive measures have to be introduced that, for example, stop people from dining together and so on. I mean, we need to test that more, John, but I think beginning to have a sense of what the threshold incidence is for the system to be able to cope, and then to also understand what gets overwhelmed if that incidence is exceeded is hugely important for being able to really work out whether or not the system is performing well enough for economic and social life pretty much to go on, despite the fact that the virus is still circulating. For me, that third part is at the center of what John and I have been calling COVID readiness, is being able to know what level of infection you can just about live with in terms of the maintenance of various services versus the level of infection that actually overwhelms systems, and then trying to keep within that manageable limit and being able to talk to each other about it as public health professionals. You know, we can manage spikes if we're at less than 50 per 100,000. John, am I characterizing you correctly?
I think it's very, very neat summary, David. I think there's a slight element of sophistication which says as the numbers go up, there's a step between managing spikes and movement restrictions, and that point is when they're flood testing an area and putting high levels of communication in. They've lost the ability to target directly, but they're still trying to hold a little buffer, if it likes, between suppressing spikes and closing the place down. Yeah. But they find that very unsatisfactory. They find that very broad brush, and they feel very out of control at that point and anxious.
So that's the other point, is that if you're dealing with an outbreak or a series of outbreaks, and you are close to that threshold where you're going to basically lose control, it's a very disturbing sensation. You don't fully know inside yourself what's happening. And it always is tough to be weathering that moment. And with this constant up and down of the COVID all over the world, what I'm sensing is a lot of anxiety among public health professionals basically looking at each other and asking the question, are we managing to hold it back, or are we about to be overwhelmed? And normally when you're doing public health, you don't get these moments coming too often because they're very disturbing to your way of thinking. You're expecting normally to have things under control in public health. And so this phenomenon we've had in different parts of the world during the last 15 months of numerous situations where public health people are wondering what is happening and whether they're on the edge of a precipice is a challenging one. And I'm talking quite a lot to colleagues who are just saying, this is not an easy time for us. Nobody is walking around with their tail in the air saying, haha, we're doing great. Nobody in public health feels like that at the moment. I want to move to the second big theme of today, tight now, and that's COVAX. I've talked before about COVAX, which is the scheme that has been set up in May last year to enable a transparent and open allocation of scarce vaccines around the world. And this scheme is interesting, and several of you asked me about it, so I was with Catherine checking it up. This scheme is interesting because it's designed to enable everybody to get vaccine by doing pooled purchase and then requiring some governments to pay the full price for the vaccine and enabling the governments of around 96 countries to obtain vaccines at highly subsidized prices. But it's an overall scheme. I mean, sometimes when we're talking about COVAX, we present it as the scheme for poorer countries. But the COVAX scheme will work and will enable everybody to access vaccine only if all governments buy as much of their vaccine as possible through COVAX. And it's come to me in the last 2 weeks that that last part of what I just said is really important. COVAX will work if all governments use it to source their vaccines. Yet, inevitably, that's not happened because governments get impatient about waiting in line and all want to try to get to the front. And it's become a huge competition between national leaders as to who can preside over the higher vaccination rate. So the competition for accessing vaccines has become cutthroat. And the COVAX scheme is not being properly used. And so the result is that COVAX is being used to route vaccines towards poor countries. COVAX has shipped 32 million doses in the last month or so to 57 countries, including 43 of them as developing countries. But COVAX itself is not working as it should have been. If it had been the place, the go-to place where which countries would get their vaccines, they'd get them cheaply and they'd get them transparently, then the whole scheme would work. But if it just receives the bits of vaccines that are left over after the rich countries have gone direct to the manufacturers, negotiated their own arrangements, and then COVAX gets what's left over, inevitably COVAX will get less than it believes it needs. You just have to look at the current state of the battling between the European Union and the United Kingdom to see that really nobody wants to give up their place in the vaccine queue. And they are now getting to really sharp moments where they fight over the wording of contracts as to whether or not Group A or Group B should be at the front of the queue. So COVAX is not being used as it should be. And that creates a problem because it means that COVAX will get the vaccines that nobody else wants. COVAX will get the vaccines that are left over, as I say, after the bidding war is over. And there are going to be challenges because the supplies getting through to COVAX are not at the level that they were intended to be, and that's going to lead to growing frustration on the part of governments of poor countries about the massive inequity in vaccine access, just at a time when the virus is really causing really massive problems in poor countries as well. So, I mean, I am utterly committed to trying to get COVAX to work. I think it's really important that we don't give up on it. And there's quite a lot of work to be done to help ensure that enough supplies come into COVAX, particularly supplies from the Serum Institute of India. It's also important to get some of the newer vaccines through the licensing process in WHO, particularly the Johnson & Johnson vaccine, which has been licensed. We need to get that out. And then we need to get donations coming into COVAX from countries that have got excess supply, like Canada, US, and UK. We need to try to get the vaccines that are not yet completed their review because of issues with getting data from the manufacturers, like Sinopharm, Sinovac, and Gamaleya, get them through COVAX. And perhaps most importantly, it is necessary to try to increase the production of safe and effective vaccines, and really important to make sure that there is capacity to continue to update these vaccines as new variants are discovered. So in summary, I want us to keep working on the pandemic as a pandemic with good infection control measures. I want us to maintain that narrative strongly and keep stressing that people are the solution. Therefore, we must empower people to solve the problem. I want the work on the epidemiology of the virus and the variants to continue, and to continue global, because this pandemic is really very ferocious at the moment. I want to keep looking at the levels of sickness and death associated with the pandemic. I want to make sure that the vaccination work is backed by a properly functioning COVAX, and also with a constant review of which vaccines are being used where, so that there is some proper charting. And that means I want to see a global COVID-19 program functioning in the same way as we've had a global polio immunization program. If ever we needed a global program, it was for this. And then thirdly, I want us to continue remembering that COVID is hurting poor people, poor communities, poor nations, and that any thought about post-COVID must focus on the poverty impact of COVID. And rather than build back better, I want to talk about leaping forward fairer, because we're not going to be able to go back to pre-pandemic life, but we've got to find ways to move forward whilst ensuring that poorer countries and poorer people are not unfairly disadvantaged. So fairness is key, moving forward is key, and because we're dealing with exponential problems, we have to leap. Okay, so thanks for the chance for sharing my thoughts with you. And I would now like to go to Twee. Twee will talk to us about a few things, and then we'll come back for the discussion. Twee, please.
Thank you, David. And I would love your thoughts on leaping forward fairer. So please do put that in the chat as well. And any other questions you may have, now is the time to put them in the chat so we can answer them in the second half. So over to a little bit of the intermission quiz. I'm going to launch the poll now. We have 3 questions. The first question being, drug-resistant and extremely drug-resistant strains of which infectious disease have been identified? Influenza, tuberculosis, or pertussis, also known as whooping cough or Bordetella pertussis. Question 2. Roughly 11.3 million doses of vaccine are being administered daily. To date, what percentage of the world population has been vaccinated? 3.1%, 12.4%, or 30.2%? And the last question is more just to learn about you and what barriers you might face with regards to testing. If you wanted to be tested for COVID-19 right now, which of the following below apply? Now you can select more than one. You don't know how to get a test or where to go, is option one. Another one is you would have to pay for it. Third, you'd have to prove that you've been exposed. Fourth, you'd have to satisfy other criteria, for example, your age, where you work, for example. 5, you'd have to book an appointment rather than just coming in, walking in. And then lastly, you would have to travel far. So I think we would be quite interested to hear from you what the situation for testing is where you are from. So while those results come through, I will spotlight our beautiful illustration from Chris. Welcome, Chris. How's it been for you this morning?
Very interesting. I'm just, oh, sorry. In fact, I used up the space, so I was just carefully trying to resize the image to get a bit more real estate for the second half.
Beautiful. Beautiful.
So yeah, some bits have gone a little bit wrong, but I'll be fixing that in a second.
I think it looks great. And great to see you picked up some of the sayings there and holding back the flood. Fantastic. Thank you, Chris. We'll come back to you. We'll come back to you nearer the end.
Great.
Well, let's see what you have all responded. For question 1, most of you did get this right. Indeed, it is tuberculosis. Both drug-resistant and extremely drug-resistant strains have been identified. On question 2, you have this right. 3.1% of the global population has been vaccinated so far. And number 3, interesting to see, many of you, a couple of you don't know where or how to get a vaccine, to get a test, sorry, which is interesting. And a few other barriers that many of you faced with, the most common one being that you would have to book an appointment. And 32% of you would have to pay for it. So that's interesting for us. We will keep note of that. And for now, I will hand you back to David for our question and answers and inviting people to share their thoughts from where they may be joining from. Thanks, David.
Tui, do you enjoy doing these trigger moments in the middle of our open online briefings? Is this an invitation for you?
I do like it. I think it's a nice, it's a fresh piece in the middle of our sessions, which can be very, very heavy in this time of difficult situations for many of us. I hope everyone enjoys it. I always love to hear feedback as well.
I was just thinking about how heaviness, you know, I was talking about how I think for public health people, this is a very tricky time. I think for people in clinical medicine, it's difficult. And then for people on the 0 hours contracts, as John was just saying. And so I'm pondering on the sort of very high level of anxiety that there is in many venues, obviously coupled with other places, other communities that are relatively relaxed. But I'm just very much focusing on the continuation of this thing, really causing a lot of distress in many different parts of the world. And Tui, please keep your ear to the ground. Everybody keep your ear to the ground. If there are ways in which any of us through our actions can just help to reduce that sense of sort of confusion and uncertainty, do let us know if there are ideas that you've got for helping us all to navigate our way through this. And I'm going to invite everybody to make some remarks. And Kath, what I'd like to do is, Catherine, if you wouldn't mind just telling me who you've identified and what thoughts you have for how we fill the next 19 minutes. Over to you, Catherine.
Sorry, delighted to do so. We've had comments from Anne and Marianne and Loy Rigo, thank you so much. But we also have some people who are online, including Karen Kaplan, in incredibly early time zones. So if they're available, that would be great. And we were delighted to see Andre Hoffman is online today. So if Andre, if you're available to speak, we would be really pleased.
Okay, so that's good. And now what I'd like to do now is perhaps to invite Anne Hendricks. Have you got any observations you'd like to mention? And after that, I'd like to invite Marianne, Loy Rago, and Joe Nichols if they want to speak. But Anne Hendricks, did you want to come in at all?
Hi, and thanks for inviting me to come in. I'll just share a couple of quick things. We've had a lot of success in Malawi recently where our creative national chapter there, the Movement for Community-Led Development, scheduled a call-in show, a call-in radio show for community members to call in their questions, and then they, about the vaccine, and then they took down all the questions and they found scientific experts in Malawi that speak Chichewa. And they got a panel together to answer the questions. And then the government radio program didn't want to take a chance on that. So then they had to get permission from the National COVID Task Force, which they did. And then they had a radio call-in show where the whole thing was in Chichewa by scientific experts talking about the vaccine, answering the questions that had already come from the communities. So that was really popular. And then that turned into a TV program about it as well. So, you know, I know you all know this, but you can't underestimate the amount of questions and concerns that people have about the vaccine. And all these formats are really helpful in order to help people get the good information they need. And second, in Benin, our Benin chapter, which has been doing a lot of work around the vaccine information dissemination, found the complexities in Europe to be a huge setback, because now the folks in Benin are saying, like, see, we told you these vaccines are no good. We see what's happening in Europe. If Europe's not going to take the vaccine, then we're not going to take the vaccine. So they're scrambling, trying to figure out how to respond to that setback.
Thank you very much indeed. The on-off business with AstraZeneca vaccine and the association with clotting that came to a head last week seems to have had an enormous, more than ripple effect, like a giant wave going around the world. So, Anne, your point is so well taken that people don't necessarily pick up that it's the AstraZeneca vaccine. They just see it as vaccines. They see it as questions about safety. And it's very disturbing, super disturbing, actually, to vast numbers of people, hundreds of millions of people. And you're so right that sometimes those of us based in Europe forget just how profoundly these pieces of information get amplified as they move around the world. And it's very, very difficult for people to manage uncertainty. Gosh, thank you for helping us with that. I wondered, going on, Karen Kaplan, did you want to, we love seeing you. I know that you're keeping a close eye on things in the US at the moment. It'd be lovely to hear from you how things feel viewed from where you are in New York at the moment.
Hi. Well, I think racial equity and access continues to be the biggest issue here. States are opening up, you know, 16 and older or 18 and older for people to get vaccines. And that's not because of the amount of doses that we have available. It's because we have so much extra available. It's because people aren't choosing to get vaccinated. You know, the majority of healthcare workers in America are not vaccinated. but there's a lot of positivity. I mean, it's, you know, I don't want to take up too much time. There were really interesting things that happened today. It was nice to see you, David, in the World Food Prize event today. That was really great. And tying COVID and poverty and nutrition and really, really great stuff happening. And the Catalyst 2030 awards were also today, I guess yesterday, whatever. And Ray Chambers was talking about, you know, 1 million community health workers and how to tie in COVID, PPE, back and poverty, and trying to do more with that, and how to expand that program with Living Goods across Africa, and their partner Last Mile Health and some others. So that's all. I don't want to say anything else about the US. It's, you know, we're a hot mess.
No, but the fact, Karen, the fact that you were able to witness some really good stuff happening on the East Coast, and people of good heart like Ray Chambers finding an opportunity to actually really influence others for the best, and just thinking about Last Mile Health and the incredible contribution they've made. Gosh, that's exciting news. And I suppose I'm seeing that as well. There's a lot of enthusiasm on the part of people of good heart to really behave differently, behave more openly, to connect better, to be more systems thinking. So that's perhaps you're seeing some of what I'm beginning to see, and it's wonderful when you can pick it up. Thank you very much indeed. And thank you for staying up late. It's very kind. Loy Rago, please. I'd love it if you could react to what are the slogans for what comes next. Loy, please. I have to get you to demute yourself before. Thank you.
Unmute. Yeah, well, I love your new slogan, moving forward fairer. Popularize it and elaborate on it. Make it an agenda for action. And then, you know, people can implement. And it builds on building back better, which is a popular slogan, which we have been using for a long time now, 15 years, in the disaster management sector. So building back better. And the other was a kind of semi-offer, that is that I live in Egypt. I am from India and I'm in active touch with India. And of course, I lived for 5 years in Myanmar before this. So in each of these three countries, if there are specific suggestions on whom to collaborate with or actions to be taken, I strongly believe that actions need to be planned and taken country by country, quite apart from the regions, and globally, of course, all of us are doing this. So in each of these three, any of these three countries, if there are any suggestions, India I am most familiar with, but the other two, and I'm in touch with Myanmar and Egypt. I live in Egypt. So this is an offer, and happy to hear from anybody. Yeah, thank you. That's all I have to say.
Wonderful, Loy. Thank you very much indeed. And I think that working together around the different countries where you have experience is hugely important. Really, really good. Thank you, Loy. Would like to now quickly see whether we can get some remarks from Sarah McFarlane. I know your video is not on and you haven't agreed, but I'm just going to ask you, did you want to talk a little bit about your initiative? If you do, just please unmute and just come in. Hello, Sarah.
Okay.
Go. Off you go.
Thank you, David. Well, it's a little bit early days, but a group of us are planning an initiative which we're calling a people-to-people initiative on the concept of getting a vaccine, giving a vaccine. This is something that's actually been bubbling up in the UK, but I don't think that it's sort of universal over the world. So we're calling the initiative Get One, Give One worldwide. And what we're trying to do is to make contacts with all our contacts and their contacts, and to try to raise some, we're trying to see it as some sort of working together, holding hands around the world. So it's more than fundraising, but a sort of demonstration of people's caring and good heart, as David put it. And I think it would be wonderful to, if any of you are interested, to help us. Obviously, we need to connect with all the various networks. That's pretty onerous. So we're working pretty hard at the moment to get a website up and to try to go live. But if any of you can support us, it would be quite wonderful.
And what's the best way to connect? Through, will you, have you got stuff available that people can access?
Yeah, well, we'll put the website up very shortly. So, but anybody can communicate with me. I don't know how to give the group my email address, but can you do that, David?
No, just to connect with us, and we will pass you on to Sarah. Just so
that would be fantastic. Thank you very much.
Yeah. So thank you, Sarah. And there are one or two groups who are trying to establish get one, give one type schemes. But Sarah's one is quite far advanced, and honestly, I'm going to do what I can to encourage the integration of the various different ideas so that we get the sort of scale that will make a huge difference.
Yes, there shouldn't be competition. We're all doing the same thing. And by the way, we had decided to raise money for COVAX. Some of the other schemes, for example, will support UNICEF or the WHO or the COVID response fund.
I'm super glad that that you're doing it for COVAX, Sarah, because of my commitment to find a way to get COVAX to work. Okay, thank you. Nendirmwa, can you hear me? And how good is your internet today? I'm just...
Hello, Mr. David. Good morning from Nigeria.
Hello. We've been connecting with you over quite a long time.
Yes.
And just to, I've come to you in the middle because I don't see you very often here. Is there anything you'd like to say from where you are in Nigeria?
I just text a comment now in the chat box. So presently, vaccination is ongoing in Nigeria, although not every part. So it's scarce. Not every area that covers the vaccination. So I think a proper measure needs to be put in place, which has to do with advocacy, sensitization of people. The mindset of people presently is negative concerning the vaccination. So a lot are having the mindset of maybe it's not proper, we take the vaccination presently. So I think maybe I could also be a part of it. So sensitization needs to be done. So people in the urban communities are also having such a mindset. So what about those in the rural communities? So I think a lot needs to be done in Nigeria to make people realize that the importance of this vaccination. Thank you.
Thank you. And so important what you've just said. Can we go to Joe Nichols, who's in Nairobi? Joe, please.
Thank you. Yeah, I mean, as you know, the cases are still going up in Somalia, Kenya, Ethiopia. I think the positivity rates over the last few days in Kenya have been at about 20%, around there. And a lot of reports that the hospitals are full in all of those three countries. One of the things I just wanted to, I'll definitely touch base with Sarah about the get one, give one. I think it should be get one, give more, or get one, give some. But I mean, I guess that's something which people will be able to choose about. I think one of the big challenges is that of course, the equity is at a global level, but a lot of the successful appeals to individuals to give money tend to be at a very local level. And certainly that's the case when you look at how remittances work, how zakat type charity works, and even how people can be persuaded to do something on the spur of the moment. If they can see where it's going to help, it seems to have a bigger impact. So one of the challenges in getting that sort of thing off the ground somewhere like Kenya might be, how do you make it real to the people in Kenya, especially because the ones who are getting vaccines here are getting it from this little stock of COVAX that the government's received, which means that someone else isn't getting a vaccine from that little stock of COVAX. But yes, I'll definitely be in touch and hope to explore the idea further.
And thank you very much for just this vivid reminder that the issues are not yet real for many people in, for example, the kind of Kenya, Somalia area where you're working. And that does make the implementation of vaccination programs super difficult. It's a very, very delicate moment. And I'm grateful to you, Joe. Super good. I just wanted to finish by inviting Marianne to take the floor. You put a comment in quite early on, Marianne, and then I'd like to go to Twee, to Chris, and then say farewell. So Marianne, would you like to come in, please? I've lost you, Marianne. Have you gone?
I think we have lost Marianne.
Okay, all right. Well, she was here just now. Okay, oh dear. Thank you. So Peter Scott Bowden, please. Peter, are you there? Or have we lost you? There you are, Peter. Come in.
Yeah, hi David. As I wrote in my notes, it seems extremely serious. We've got over 95% of needs unmet. And I was just wondering two things on further reflection. Do we have a problem with political will, money, or availability of the vaccine itself to address the supply chain issue of increasing that percentage?
Thank you, Peter. It really is a supply issue. Two things. One, the supply is contested and there are too many people going for too little vaccine. Two, there's a lot of manufacturing starting up, and that means that expected batches of vaccine that were going to come on stream and into the supply line are sometimes not appearing because of manufacturing problems. And that's the two situations. One, there's not enough, and two, there are teething troubles with manufacturing. And so there is a huge amount of squabbling over what vaccine there is. And I'm afraid a small number of countries are actually hoarding more vaccine than they need as a kind of insurance policy. And so it's created a really skewed situation, Peter. And I mean, it's 100 days approximately since countries started to vaccinate, and about 460 million vaccine doses, nearly 500 million, have been administered. But 75% of these vaccine doses have been administered in just 10 countries. And a high proportion of these vaccines have been administered in the US. It's just a very skewed picture. And so 460 million doses administered altogether, Peter, but COVAX has shipped only about 30 million of those. And that's how the vaccine started going to poor countries. But the reality is that it really is skewed towards rich countries. So it's a series of vaccines that are in short supply, and the rich countries have just sucked them up and said, it is a priority for our nations to have these. And there's nothing at the moment stopping that, because other national leaders are in a way copying the example of rich country leaders and perceiving that it is their job to do everything they can to get vaccines. So the competition to get vaccine at the moment is hotter than ever. And that's why COVAX, which does depend on a measure of restraint and mutual responsibility by leaders, COVAX is just finding it hard to hold its own in this free-for-all. So we will keep working on that. I personally will keep really focused on it, and I'm sure all of you will too, because it's not just calling for equity. We need to act for equity right now, and we need to do that however we possibly can. Twee, back to you, please.
Well, thank you all for joining us today. We're coming to the end of our 12th session of Series 3 of the Open Online Briefings. Just a reminder, we won't be having a next session next Friday, but we'll be back here at this same time on the 9th of April. And so look forward to seeing you there. And before we go, let's have a look at Chris's illustration. Looking great, Chris. Thank you for this. It's fantastic. And great to see you've got the radio there, the example from Malawi.
I think the thing is that I'm really trying to like capture a snapshot of what we're talking about, because what I've realized is that you now possibly hold one of the biggest publicly accessible bodies of my artwork, you know, and I realized that if I can just look back at them and sort of see what's been going on as we sort of go through all of this. So what we're all trying to do, me and the other scribes, is try and capture the moment, because we know 6 months' time the situation might be different, but you know, it's nice to be able to look back at it and see where we were. Well, let's hope it's different in a good way anyway.
I think it will be. I think that we are contributing to the advancement of knowledge and understanding, and you are just great. This is especially good. Everybody, thank you for joining, and have a good week. Have a good break if you're able to take a break next weekend, and look forward to reconnecting on the 9th. And best wishes to everybody, especially to Twee, to Catherine, to John, and to Chris, and to all who work behind the scenes, but it's most of all to all of you. Bye-bye.